Thank you. First of all, I would like to thank the organizers, AstraZeneca, and all the esteemed audience for giving me an opportunity to talk on hyperkalemia. We must have treated hyperkalemia n number of times. Creatinine in potassium more than 5.5, alarming. Calcium gluconate, glucose insulin drip, nebulization, diuretics, potassium binding sachets, sodium bicarbonate, we all have used. If not controlled, then dialysis at times. But I would like to address this topic with the recent update in this.
Please silent, please.
Which is going to change our day-to-day practice also in the coming years. Before starting the talk, why it is important? Because as we all know, CKD is increasing like anything nowadays. 1 in 6 adult patient in India is suffering from CKD, shown by the Sick India study across the major national cities of the country. And all the guidelines for treatment of CKD suggest role of RAS inhibitors, all hypertension guidelines as well as diabetic guidelines as well as cardiac guidelines for the heart failure suggest role of RAS inhibitors as well as SGLT2 inhibitors. So main problem with the RAS inhibitor is barrier is hyperkalemia. So as population patients are increasing as well as role of RAS inhibitor is significantly there, we'll be facing day in day out hyperkalemia patients. So I had kept today's talk mainly in the case based discussion so that it will be a useful talk for all of us in the day to day life. So we are seeing a Mr. R, 65-year-old gentleman, suffering from CKD stage 3B with EGFR of 33 ml. He is also having hypertensive heart failure with reduced ejection fraction of 33%. He had episode of hyperkalemia 1 year ago. Urine ACR is 238, potassium is 4.6, blood pressure is controlled, cardiac markers are controlled. He is on sacubitril valsartan, that is ARNI, bisoprolol, that is beta blocker, furosemide diuretic, spironolactone, that is mineralocorticoid receptor antagonist, and dapagliflozin, that is SGLT2 inhibitor. Reason for emphasizing this is that he is having utmost care for the CKD as well as heart failure with reduced ejection fraction. This is a slide showing goal directed medical therapy in which we can see that all the 4 pillars, mainly there are 4 pillars. One is beta blocker, one is ARNI, one is MRA, one is SGLT2 inhibitor. Patient is receiving all the therapies, that is GDMT, guideline directed medical therapy. That is the goal of our daily treatment for the patient, as it has clearly shown mortality benefit, reduced hospitalizations, reduced cardiac events, reduced kidney events. Now coming to case, one fine day, Mr. R again presented in our OPD with potassium of 5.9. Now what to do? Before answering the question what to do, let's dwell into the topic furthermore, why he has developed hyperkalemia. Let's look at the data. As we all know, with increasing CKD population, with increasing stages of the CKD, there is less and less amount of potassium excretion from the kidney. So basically kidneys will not be able to excrete the more amount of potassium. So such patients are at very high risk of the hyperkalemia, specifically when they are receiving ARNI and spironolactone. With increased stage of CKD, there is direct correlation that hyperkalemia risk increases. And why this hyperkalemia is important? Because we all know that hyperkalemia has direct correlation with the cardiac. Cardiac arrhythmias can occur, sudden cardiac death, increase in the chances of hospitalization, increased mortality is seen with the hyperkalemia in the various studies. This is very interesting study, US based study. Usually when hyperkalemia comes to our mind, we usually think of hospital setup, admission and all that. But hyperkalemia is not just only a single time event, it is a chronic recurrent condition requiring long-term treatment. In these studies, specifically done in the CKD population, authors have shown that first recurrence of hyperkalemia was there in more than 50% of the patients in less than 1.5 months. So whenever we treat hyperkalemia, always think that it will recur in most of the patients, not if not all. So with this background in our mind, let's come back to the case. Our Mr. R has 5.9 potassium. Reasons were CKD stage 3, as well as he was on ARNI and spironolactone. So he is having a high risk for the hyperkalemia. Now next most important question is, what can be done for such kind of cases? Of course, first and foremost thing is reduce the dietary potassium. We all know banana, coconut water, lemon water, etc. are having a high amount of potassium in the diet. So diet has to be strictly monitored and dietary potassium restrictions should be carried out. Conventional calcium polystyrene sulfonate, that is K-bind, that we usually use in our day-to-day practice, can be given. Reduce ARNI, discontinue RAS inhibitor, that answer will be given in the coming slides. These are the things can be done for the hyperkalemia management, limiting the dietary potassium intake as well as reducing the medication that impair the potassium elimination. Diuretics can be used, mainly loop diuretic, that is Lasix or torsemide can be used. Sodium bicarbonate can be used if patient is having acidosis. Potassium binding agents can be used orally. Calcium gluconate and GI drip mainly for the hospitalized patients. All the guidelines across the globe strictly suggest us to use RAS inhibitors in such kind of patient, and it should be continued. So basically this is the study in which authors have shown that whenever there is episode of mild hyperkalemia or moderate to severe hyperkalemia, there is 40 to 50% chances that ACE, ARB or ARNI, that is RAS inhibitors, will be reduced.
Excuse me, sir. 2 minutes left.
Okay.
Yes.
Sure. So basically in such kind of scenario, there will be rise in the morbidity as well as mortality and increased chances of hospitalization. And another study has also shown that once RAS inhibitors are discontinued, then reinitiation will be very less in such kind of patients. So basically we have seen that conventional therapies have significant limitations. So coming to the novel potassium binder, that is sodium zirconium cyclosilicate, that is the main molecule that we are talking about. It has been recently launched in last 3 to 4 months with the brand name of Lokelma from AstraZeneca. It has been available since last few months only, so there is limited amount of the awareness that persons are having. Sodium zirconium cyclosilicate is a molecule with an average binding site of 3 angstrom, which is exactly the size of the potassium. So it is a highly selective molecule to be given orally, and it has a good potassium lowering effect. There are various trials done in the Western world. It has been known and used in the Western world since long. Harmonized trial was the pioneer trial in which authors have given Lokelma in the 10 gram TDS dose in the first 2 days, then maintenance dose for 1 month, and then extended maintenance dose for 1 year. In this, we can see that in the first 24 to 48 hours, roughly 0.7 to 1.1 millimole of reduction in the potassium was seen, and 98% of the patients were able to achieve reduction in the potassium. In this graph, similar, whenever it was being used, it can control the potassium for a long term without any major side effect. This RCT data is better replicated in the real world also. In this optimized study, authors were able to continue RAS inhibitor despite hyperkalemia with the help of sodium zirconium cyclosilicate. And in the same this galvanized trial, because of the SZZ with RAS inhibitors, we were able to reduce the hospitalization rate. This is a comparison of the sodium zirconium cyclosilicate with the patiromer and calcium, our routine K-bind agents. This is highly selective agent with rapid onset, and main thing is about this molecule is there is no major GI side effect that we routinely see our potassium binding agents. This is another study in which authors have shown that there is significant reduction in the inpatient hospitalization with this molecule. So this is the last final slide from our KDGO. Given recommendation about the RAS inhibitor should always be used in such kind of patients with heart failure, CKD, diabetes, nephropathy patients. Whenever there is hyperkalemia, we have to review our drugs, we have to review our potassium intake in the diet, we have to consider diuretic, sodium bicarbonate and potassium binders. We are supposed to reduce the dose or stop ACE ARBs as a last resort. One should consider novel potassium binder agents that has shown significant efficacy. So coming back to our case, with the ongoing GDMT, we should add SZZ in the patient so that we can control the potassium. To summarize the talk, achieving optimal use of GDMT is needed, is the time important thing. Hyperkalemia is barrier. However, with the help of SZC, we can reduce the potassium rapidly as well as we can achieve the sustained potassium control. Thank you.